Very good morning to all, respected dear seniors and dear friends. I, Dr. Reena Rathi, Secretary, Nasik Adolescent Health Academy Chapter, welcomes you to this ninth session of PATH, that is Pediatricians Action for Teenagers' Health. It's an online session, and the idea behind it is our Maharashtra IAP President, Dr. Ramakant Patel, sir. Before introducing our first speaker, who is Amitabh Bachchan in Adolescent Healthcare, our Naya sir, I would like to hand over our mic to Dr. Ramakant Patel, sir, to have a few words. Over to you,
Thank you, Reena. Thank you, Reena. Very good morning to all. And good morning, Nair sir, Vaishali ma'am, my friend, backbone of this program, Dr. Atul Kanikar, and ably supported by Reena, Trupti, Sulabha, Chandrakant Survase. I am really grateful to this team, who have made it possible months after months, this adolescent health chapter or path ably nominated or christened by Atul Kanikar for this program. And friends, Atul is our first generation adolescent health practitioner in Nasik. And I have got many times I send my patients to him for counseling, or sometimes I use wrong word that you have to go see to this doctor, and he's expert and he is a doctor, pediatrician and therapist and everybody. And sometimes my adolescent patients fire back. Am I crazy? I have got friends to talk. Why should I talk to him? And he's simply going to tell my parents what I would go and tell him. And to issue all these procrastinations in our mind and in even the adolescent patient to whom we want to refer to Atul or other adolescent health practitioners, how we should tide over this, and who else than Dr. M.K.C. Nair is going to address us on this very important and very tricky, and how to trade easily on that. So, and really also sexuality, how whether it is to be incorporated in different curriculum, will it have the same importance, and at what age and at what curriculum we should really have sexuality to be taught, and if it is to be taught in schools, and how parents are going to tell about sexuality, and who else is there to tell us and teach us, Dr. Vaishali Deshmukh ma'am. So I'm really grateful for the team path of Nashik IAP under able leadership of Atul Kanikar and Sucheta. I'm thankful you have given me a time to express my thoughts. Over to you, Reena.
Thank you. Thank you very much, sir, for your meaningful few words. Now I hand over to Dr. Atul, sir, who has moderating and guiding this ninth session. Throughout the session, sir has given us excellent speakers with the very useful topic. Over to you, sir.
Thank you, Reena Mati madam. I just want you all to say namaste to the master in sexuality, Dr. Tuteja sir. Please, sir, welcome.
Tuteja sir, namaskar.
Namaskar, sir. Madhushri Boli.
Tuteja sir is here, and that will complete that will complete the team. And now I have so many things to say about M.K.C. Nair sir, Tuteja sir, Vaishali madam, Geeta Patil madam is our permanent member. There are so many others. Swati Gatia I can't see, but Madhushri Deshpande is always there. And this program, when was coined by Ramakant Patil and of course Amol Pawar, who is the secretary of Maharashtra IAP. When I was given this particular task, I had a team of Nasik people who were quite dedicated and enthusiastic about it. So we just had a meeting and then we went about it. For last maybe 6-7 months, it has been going very, very smoothly. And today is a big day because we have two important topics which are going to be covered by the masters. And after 2 days, we have the Teachers' Day, Shikshak Din. And who on the screen is not a disciple of Dr. M.K.C. Nair sir. So we are all with the teacher 2 days prior to the Teachers' Day. So thank you very much, sir, for joining. and sir is going to talk about counseling in office practice, adolescent counseling. After that, my dear friend Vaishali Deshmukh, we are batchmates at Trivandrum PGDAP course, and we have very fond memories of Trivandrum. So she is going to talk about anticipatory guidance to parents and teens in office practice on sexuality issues. So over to you, Reena Rathi madam, for sir's formal introduction.
Thank you. Thank you very much, sir. It's my privilege to introduce our first speaker, none other than Professor Dr. M.K. Chandrasekharan Nayak, popularly known as Dr. MKC, the renowned pediatrician, counselor, and academician in the field of child development and pediatrics, has authored over a dozen medical books and hold more than 12 degrees in various disciplines, and is academic editor for several textbooks on pediatrics. Sir's famous quote, "My students and patients are my huge wealth," explains everything about his dedication and devotion. He has given and giving justice to many responsible posts, including Vice Chancellor of Kerala Health University. Over to you, sir. Thank you very much. Sir, you are muted.
Yeah. I'll share the screen. Okay. You can hear me? Can you hear me?
Yes, sir. Yeah.
Okay. My greatest admirer is my grandchild. She's going to be 8 years. And she has only one wonder in life. Wherever you go, and whoever you meet, either it is your student or your patient. Papu, how is it? Understand my point? So that is probably like a Bhararatna. Your own child, grandchild is appreciating grandfather so much. That is probably the greatest thing. I must say namaste to the office bearers of Nasik and Maharashtra AP, but specifically to my two gurus sitting here, Adul Kanika and Tutreja Saab. I'm not joking.
You are my guru, sir.
No, I'm not joking. I'm seriously saying because I have learned a lot of things from them also. I might have taught them, but I have learned a lot of things from them. After CDC for 25, 30 years, I became 5-year Vice Chancellor, came back and started this Child Development Center, named Spectrum Child Development Center, where I'm looking after children up to 24. In CDC, it was 95% less than 6 years or 90% less than 6 years. But now here, most of the patients I see is bigger ones. That is a basic difference. And one thing about this institution, there's a board sitting there which says you can pay what you want. There is no compulsion. Bill will be given, but you pay what it is. That is so I must thank my MD for such courtesies. Now, practical sense. Let us look at we all talk about adolescent for last 20 years now or 25 years. But somehow it has not percolated because we don't know how to position ourselves. A person who is just new, do not have a degree, and only heard some workshops and talk, do not know whether I am qualified, I am competent to do that. So there are 3 steps you can do that. First one, you only talk about a child guidance. Now, guidance is you are a pediatrician, you are already past middle age. You can guide anybody and you have the knowledge. You have MD and you have the knowledge. So first, I think you should start. Everybody must start a once a week child guidance. Once you start doing that and become little more self-confident, then you may convert it into child guidance and counseling clinic. Okay. And then only you should start full adolescent clinic. Why I'm saying this is because you should never get into trouble. The moment you become adolescent full-time, you need support of other specialists also. Not because you don't know it. When everything goes well, they are happy with you, the moment something goes, all sort of questions. So many years, I have seen more than 65,000 families, but I'm just giving the problem in a one particular year. Look at it. If you look at 2,045 children seen in 1 year, what are the basic problem? It's a scholastic backwardness, 70%. Now, to understand scholastic backwardness, you don't need special training. You only need one day or 2 day workshop. Attend a scholastic backwardness workshop, and you will be able to become master. And it may be environmental factors mostly. It may be low IQ, and these two are the most important: environmental factors and low IQ. Just remember this point. That is very important. Both low IQ, naturally you can't do anything about it, but environmental factors you can do a lot. Then you have a whole lot of thing called conversion or somatization. That's a dramatic presentation, dramatic recovery. I'll come back to it later. Then you have behavior problems. 103 cases in a year, where it could be oppositional defiant disorder or become graduate into conduct disorder. You may have speech problems, anxiety, and particularly now separation anxiety has become very important. DSM-5 has given separate diagnostic criteria for that, school phobia, etc. An average pediatrician with a little interest and little training will be able to manage all this. Now, scholastic problem, all you need to do is look at from this point of view. Is it a lack of intelligence? So you may be able, even if you can't do full intelligence sale, you can do WABs, okay, vinyl, scoring, which is only questionnaire, which you can do it, okay, and you can see whether it's a subject problem, particular subject child is having problem. Is it a problem of poor fit with the teacher? What are the environmental factors? Is it at home? Is it in the school? And then you think of mental illness. To screen for all this, I'll tell you simple techniques how you can screen this. Then conversion reaction, I think we must understand, because it comes so dramatically. They would have gone to many pediatricians, lot of investigations. But if you sit back cool and just look at the child, you may realize that he doesn't have actually much physical problem. It's all psychological overlay of the child and 10 times more of the mother. If he can cool down, just like I will say a story. There was a neurologist in my time when I was doing post-graduation. He used to think pediatricians are only like veterinary. But one night he came running with his baby with only in that big underwear and all. He was so desperate. He didn't have time to put on the pant and come. So as a pediatrician, became okay. What was it? Breath holding spell. So, for us, it is such a simple thing, but for a neurosurgeon, it may not be. So there are some innate, quality a pediatrician has developed, and that is all what is required in a conversion reaction. But 3 rules we must remember. There is no but, there is a psychological problem. And that problem is real to the child, and we need to interfere with that. We have to make a solution for that. Don't trivialize it and say it is malingering. No, it will repeat. It will become even worse. And the second most important point is take the parents with you. Have you done investigation? 1, 2, 3, 4. Do all the investigation once, not twice, thrice. Right. Do once and say, look, the best doctor has seen, all investigation is okay. Now let us settle down to this thing. Don't say it is psychological or have you produce it and all that. Just put it that all of us get in sometimes, buckle under pressure, something which we don't know. For us, that is a trivial cause, but for the child, it may be a big cause. And if you can manage parents like that, it will be easy to manage. Then behavior problems, of course, there are a whole lot of new things have come now and gone also. For example, ABA therapy. ABA therapy was the in thing for autism. Now that is all going back. Nobody is believing that now anymore. So many things have come and gone. because of lack of concrete evidence. But one thing has never disappeared is Freud's theories as well as this behavior concept. The basic concepts have never changed. Yeah, if there is a problem, there is an antecedent reason. There is a particular behavior which is reinforced or negatively taken away. This extinction that we can think about later. And then there is a consequence. So when you have a behavior problem, sit with the child and try to find out what is the antecedent thing and what is the consequence. When you discuss in a friendly way, the child really understands that this fellow is not an enemy. He is not here to blame me. He is not here to criticize me. He's there. And what I usually do is when the parents come this thing, child will be very anxious and don't know what to do. She will be sitting like that. I'll just put my hand like this and ask him which out of this is most irritating, and he will look both sides and then say mama, because most of the time it's the mother who actually make noise about it. Father shrewdly keep quiet. You understand? But what does that one sentence make is child understand that he is not going to attack me. The parents have not poisoned his mind. I am looking at the parents as a culprit, which is not true. But for the initial stage, child will be very happy with that. Then, of course, in 2004, when I was the national president, we made the commitment to look after adolescent. Great thing has happened after that. Now, 3-4 words I think we need to understand. And I'm sure this I must have said more than 100 times, but yet this is critical. Advice is not acceptable to present day children. Now, why I'm saying is I just had a book on last week, 2 weeks ago in the conference, 7 books were released, and one of them was premarital health counseling. So I asked my child my student to convert it into local language. And I said, be careful, don't write any nonsense, be very careful. And when she brought it, I said, the one person who would have appreciated this book would have been most respected Mother Teresa, because so nice language, not a single, negative things. But is that what our children, girls now want? No, they have other side. So other half, you write this, then the other half, you write what is their problem now. So both sides will not criticize you. This is important because most of the time our problem is if you go little overboard, they will blame you. If you don't try to understand, they will say this fellow doesn't know a thing. He is talking old stuff. This is the problem with advice. So more than advice, we should be guidance. Guidance is you have been a teacher for last 30 years. 30 years ago, students were different. Now you are different. Your guidance will change depending on the students. That is very important to change. Then, of course, psychotherapy, we are not qualified to do psychotherapy. Leave it to psychiatrists and clinical psychologists because you are talking about unconscious and subconscious mind. You may have to do a reaction, all sort of things to get it. But what we can do is counseling. Counseling is basically improving the personal growth. So counseling is not advising. Counseling do not solve all life's problem. Don't be feeling bad you could not solve the problem. Counseling is aimed at helping people make choices and act on them. This is the only sentence you should remember. Counseling is aimed at helping people make choices. They should make choices. They should understand their problem. They should analyze their problem. They should come out with the context, their home context or school context. They should come out with solution. They should pick up the best solution after that. We are not only helping them to do it. So this is the one sentence, please mark it. Counseling is aimed at helping people make choices, act on them. Counseling is a learning process. So once you have a good counseling, your personality development has happened and surely you are going to do better next time. Now, counseling has many approaches. I won't go into all this, but cognition means knowing. So the word you should remember is cognitive dissonance. This is very important. 3 words are there which will come in again and again in depression. You help them to get rid of the illogical, irrational, not correct attitudes and behaviors. It's an irrational thought, illogical thought. Instead of that, you are helping them to do rational. If you are discussing CBT, this will be in great detail. Cognitive resonance is a very important word. Affect means feeling. Feeling means we all get into affect mode. If you abuse me, I will get bad. 30 seconds, I will be very upset. But after 30 seconds, what do? Why should he abuse me? We have no problem with each other. Maybe he is in a bad mood. That is simple way. If maximum I want to abuse him, I will say, why you forgot the medicine today? What medicine for? Bipolar. You understood? That's the maximum you do. But as a clinician, don't even say that. You just think, does he have a mental health issue? That's all. The moment you put it on the other side, you won't feel bad about it. That's very important. Carl Rogers' mechanism is there. Conation means the action or behavior. And what we need to do is unlearn the bad behavior and relearn good behavior. Just a day for yesterday, I'll tell you, a 2-year-old baby, mother is there, father is out, no control. He is doing head banging. Oh, I can't believe the way he was banging against the mother. 2-year-old baby is doing head banging smartly. I just said no. Very powerful thing. But then I thought you must make up for that. Then I went there, start playing with him. I took him on my shoulder. He was pulling my, mush, all that. So, but next time if you do that, you should do the same thing. Bad behavior, you must show, that no should be powerful. But good behavior on the other side. What Jesus said, very important. Hate the sinner. Is it? Or hate the sin. Do not hate the sinner. Same principle we should be using. Then these words are important. Empathy is something which we all talk about, but we don't have. Frankly speaking, very few people have real empathy. We talk about it. Our empathy has become what is happening in the TV shows. Have you seen the TV show, the amount of empathy? They say, why are they crying so much? My child keep on, actually she teaches me a lot. She said, why are they crying so much? Why are they laughing so much? I said, they get paid for it. Why are you not crying? I don't get anything for that. Why should I cry? You understand my point? All empathy has become money-minded. All show. But genuine empathy has to come because that is where your personality develops. So if I picked up that child, first time I'm telling you, last so many years, I picked up a child, put in my shoulder and played with him because there was empathy. On one side, I had to do that sharp no to teach the mother what is the reaction it will have on the child. But on the other side, I need to convince the child and the mother that I have no enmity with the child. I like the child so much, but I don't like his behavior. So empathy is unconditional positive regard. This is something we don't think about it. Somebody is very dark. Somebody is not very good looking. Somebody is coming with HIV. Somebody is coming after having a sexual encounter and all. However much we may say we don't have a negative image, but we will have, depending on the way our mothers or parents brought us up. We all will have. So I always say, when you sit for counseling, do like this, put something into a pocket. Why? All my egos, all my negative things, all I am putting into the pocket. The next 40 minutes, I will not have all this. After that, I may have my own story. Congruence is very important. Feeling, thinking, and action should match. The person sitting in front of you is incongruent. Their thinking, feeling, actions, all are haywire. There's no relation between the two. Whereas you should be having fairly good congruence. So you're helping a child with incongruence for that. Put their feeling, thinking, feeling, and action in the similar lines. I hate him, they will say, but actually they love him. Get the point? So that such incongruence can be brought up and we can correct it. Now, always make positive statement. Do not ridicule somebody. Do not do all that. Respect for your client is the most important. Immediacy means direct mutual communication. Don't talk about your old time stories. Just understand this is the problem they have come with. I must try to find a solution to that. This is very important. Let the child or the girl come out with a solution, but you just push her into that solution. Confrontation is sometimes required. Very confrontation is sometimes, you know, you may have to point. Unbelievable. For last 5 years, I was answering as a VC. I was answering all three foreign examiners. But the thing is, language is so beautiful. They are very polite, all that. But 66, when I am answering, that fellow is telling me this is not exactly what you answered for the third query. You feel like killing yourself or kill him. But what can you do? They are so polite and decent. You answer. So confrontation doesn't mean negative. Confrontation means we need to address it. Concrete means discuss in specific terms. Self-disclosure. Western philosophy say you should not do self-disclosure, but sometimes in India it may be required. It doesn't matter, but don't offer it in the beginning. When you are finding it so difficult to get the person to the side, you may have to do it. Now, this is another important slide on counseling. We need to develop positive relations. How do you make it? Depends on each person. My face look very rough. Now, that has always been my problem. My face is very rough. So people try to avoid me at there. But once they become friendly with me, sir, I didn't know that you are so simple. My God. Last 2 years, I was avoiding you because same thing will happen to the child. Understand? Child will look at you. Okay? That is why I was making the child pull my mush. Because that is the most fearsome thing. That also is simple. It is only to be pulled. Get the point? So, how do you make a child? Previous days, 20 years ago, you could hold a child like this. And that was very, very effective because the parents don't hold a child like this. You could do it, and it used to get very good result. But nowadays, I won't advise it because even that can create problem. Even if it's not a grown-up girl, in a child also, it can create problem. So unfortunately, you have to keep the distance. And touching, which is so important in Indian culture, may not be possible. Then ventilation or catharsis. Let the person talk. Don't disturb that. But if they are going tangentially, or just stop it and say, what did you say? I think you said like this, nah? And never give them a chance to give one-word answers. Do not add what happened then, don't ask. Just describe what happened when you two went out. You know, it should be a general thing so they can keep on explaining, not give. Otherwise, your questions will stop after some time. Prioritize problem. They may have so many problems. But you need to prioritize the problem. 100 problem, what is 3? Make it 3 and then come to 1. Then client's role in the problem. We all think the other person is responsible for the problem, but we also may be responsible. Why don't we say, what was your role in creating that problem? Context of the problem. This is not there in any psychology book. At which context it has happened? Context is different for you. Context is different for me, for the child. Context is important. Then solution, the child should bring solutions. And that solution should be 3 solutions, discuss pros and cons, and come out with 1 solution. Then implement the solution, and counseling should be terminated as quick as possible. Now, when you look at childhood disorders, there are a whole lot of disorders that carried over from adolescent disorders. There are a whole lot of things that is coming from childhood. Somebody's phone is on. Just put off, your mobile is on. That's why. Okay. It could be leftover from, is it Seriga? I'm not sure. It could be Seriga. Contact disorders, hyperkinetic disorders, autism, specific learning disabilities. We have managed that. Sorry, doesn't
बाय
matter.
त्याने
We
लावलेला
are, what dear?
जाताना म्हणे ना लावून घे ते स्क्रब दिल्यावर
Okay. I don't understand, so no problem.
बाथरूमच्या मग मी
Okay.
ते करायला गेली
Conduct problem, hyperkinetic problems, autism, all this we are managed in childhood. When they become adolescent, some leftover will be there. Then you have the dependence, independence conflict, puberty related sexual issues, peer group problems, family problem, and of course, adolescent adjustment rehab. We all know this. I won't go into that. Then you have specific conditions. I'm telling you, the pediatrician need not worry beyond anxiety and depression. And little bit understanding on substance abuse and psychosis. It is not our fault to treat psychosis. It's not, but we must be able to understand what it is. We must be able to understand, but we must know thoroughly the anxiety disorders and depression, because that is the biggest chunk and we can treat with simple drugs. It could be generalized anxiety, phobia, panic attack, OCD, post-traumatic stress disorder. In one word, generalized anxiety means anxiety everywhere. You're sitting in the toilet, anxiety there also. You're taking bath, you have anxiety. Everywhere, anxiety. Anxiety plus. Phobia is not fear. Phobia is not exaggerated fear. Phobia means you have to have autonomic symptoms. I'll come to details later. The autonomic symptoms is what make the child or the person uncomfortable. Panic attack is simple. When you sit, the attack comes, it goes into peak, it goes away, but you are still worried when it will come again. So panic attack. OCD, obsessive compulsive disorder, obsession in thought, compulsion in action. Post-traumatic stress disorder, you have a trauma, huge trauma, and you are not able to. First few months, this can happen, post-traumatic stress disorder. Okay, the basic of evaluating adolescent. If you like this, you take it: behavior, affect or emotion, somatic symptoms, interpersonal relationship, and something on cognitive. But this, I think I must have said it 1,000 times, but I think this is the simplest way I've learned you can do this. And that is the symptom out of proportion to cause? All of us will have all these symptoms sometime or other, but is it out of proportion to the cause? That is the first stage. Stage 2 is you have definite body symptoms. That is the second one. And third is, because the body symptoms are severe, you are not able to do your routine work. That is very important. So I'll quickly read this. Anxious, sad, angry, irritable, everybody will have, don't worry about it. Do you feel your symptoms are out of proportion? Tick it, yes or no. Do you frequently have any of the following symptoms? Sweating, palpitation, all that will be for anxiety. Sleep disturbance, appetite disturbance will be for depression. Then you have, is it affecting your daily routine? And next 3 things are very important. This is all what do you require to diagnose, what you call depression. You are good for nothing. If you keep on feeling you are no good for nothing, okay, worthlessness, just write worthlessness. There is no future for you, hopelessness, and life is not worth living, and you have helplessness. There's one more. Worthlessness, hopelessness, helplessness. If you have these 3 constantly for some time, you definitely have, depression. You don't have to consult anybody. That's very important. Then, of course, you want to harm yourself. That is very important. Then post-traumatic, again, I'm saying the first step is a catastrophic trauma. Then you have intrusive recollection. That means it keep on coming into your head every time. And that will produce autonomic arousal. And the last will be you avoid. Okay, imagine you are afraid of a cockroach. It is not because cockroach is dangerous. It's because autonomic symptom that created. Obsession, thought, compulsion, action. Now, cognitive symptoms have plenty of cognitive errors. The error in your thinking, that's the what else? Plenty. I just put 3. Overgeneralization, maximization, negative, minimize. In the school setting, you don't have to ask all this. Just ask, tell me 3 good things about you. Tell me 3 bad things about you. They will be saying so many bad things about them, but they won't know, they will have nothing to say good about them. So they themselves don't think good about themselves. How can they, this one? And thought process is irrational, illogical, unrealistic. I said it before, but I think remember these words are important. And biological, of course, you have sleep, appetite, and libido affected, sexual interest affected. Then if you look at some data, there's a huge data from normal children in the community, and we did studies on them with no complaints whatsoever, just picked up. What we find is 14.4% have anxiety disorder, and out of which a majority also had concurrent depression. Okay, this is very important. Now, this study for the first time showed that anxiety and depression can go together, and not only depression, anxiety also can lead to suicidal ideation. Anxiety disorder is more severe in those with a depressive disorder. Depressive disorder is more among those with anxiety disorder. More adolescents with anxiety disorder have multiple mood disorders, and concurrently present in 24% of adolescents with AD. So 1/4 of anxiety disorder will also have depression, but fortunately, the drug of choice is the same for both. Of course, the approach is biopsychosocial. What is the biological part? There is a neurotransmitter, so that can be corrected only by drugs. The psychological part is cognitive error, that can be done by counseling, or even more specific, the cognitive behavior therapy. And social, of course, is social support. I won't go too much into it. Atul is an expert in CBT. I give an example. I am socially awkward. What will happen? The thought is I am socially awkward. The feeling will be anxious. Behavior will see teens sit in the corner alone while in a party. So in a cognitive behavior therapy, what you change is not a behavior. Mind it. The thought. I am feeling awkward. So instead of that feeling, can we bring in little more positive feeling about it? Forget about all the negatives about you. Can you say one thing positive about you? That is how the cognitive behavior therapy. It takes time, days, months. But at every thought has been questioned, challenged, and a different thought, alternate thought has been brought in. Transference and countertransference, Freud's idea. Transference is the attachment the child will develop towards you, which is very good, because that attachment is what make him or her do whatever you say. But mind you, that should not go the other way around. Countertransference should not have. You should not develop unwanted attachment. The moment the child is out of your room, forget about the child. If you still think about that child, then there is a beginning of a problem. Don't do that. At that 30 minutes, 40 minutes, nothing in this world matters except that child. But the moment the door is closed, because this happens, many adolescents will tell, they feel bad when you show the same affection to another child. So I always say, show the watch and say, your time is up. Now it's the time for the next child. And drugs, we pediatricians don't bother much about it. I won't advise you to become fanatic going after drug and all that, because bad experience have been there, because the lobby is so strong, they may actually try to put your child into trouble. All the same, we should be able to pick up problems, whether it's alcohol, cannabis, heroin, opium, whatever it is. How do we pick up? That is important, because 63%. A very recent study, 2018 had shown Childline India, 63.6% coming for treatment were introduced drug at the age below 15 years. And now, even in Kerala, we understand a lot of schools have problem, particularly girls' schools. So I think we need to take it a little more seriously, at least as a parent. Cause will be, of course, availability, celebrity influence. Most of the new generation, and I won't say most, many of the new generation film actors, this thing endorse drug. I'm not taking they take drug, but at least their statements actually endorse drug. That's not correct. Then lack of self-motivation, nothing else to do. When the child come home, he doesn't know what to do. Our young days, we come, throw the book out, even before trying to eat something, you are out to play. None of these things are available because child safety is an issue. Whole lot of, you can't blame the parents. There are a lot of safety issues. So child is put in the room, they don't know what to do, they only can do nonsense. Poor family dynamics, because I think we have moved away from our old tradition of loyalty. The loyalty, in fact, it has become in a bigger circles. If you talk about loyalty, you are a bloody fool, they will say. What are you talking about loyalty? What is this loyalty? Yes, I believe in it. And now 41 years have passed. I believe 100% in loyalty. And that is what the stabilizing force in our life. And we must say this to our children. Teach our children that nobody in this world love you as much as your parents do. But nobody in this world behave as badly as your parents. Tell that part also. They will behave badly because they are too much concerned. And whenever there is concern, you overreact. I agree. You get the point. That is very important. My grandchild went to one school. We paid so much money, international school and all. Within 3 days, she said, I don't want LKG. No, I won't go there. But now she go to a school where as soon as you enter, the teachers come and hug her, take her inside. Now she doesn't want to leave the school after 4 years. She says the 5th standard will come. I said, what will happen after that? 6th will come. She is waiting for the school to add, more classes so that she can continue there. That is what affection is. And such a child with such a teacher, such a school will not get into drug addiction. That's very important. Then consequence, they have irritability, inattention, anxiety, and suicidal ideation. So whenever the teachers see any of this, inattention, or the doctors see inattention, irritability, anxiety, suicidal ideation, we should think about it. Then, of course, we know the serious one, psychosis, hallucination, and delusion. We have a false belief that psychosis doesn't happen in children. Yes, it is. Though common, but you cannot miss it. Very often, it may be taken as something else, but I think the child also can have delusion, unshakable false belief. Very important. And the drugs, it's an old slide. I have not changed it because even now Paul Russell vouched that this is the drug of choice for pediatricians. The published information, he says, do not go for new drugs. You be comfortable with one drug and keep using it. You will never get into trouble. For, of course, ADHD, atomoxetine, we know, anxiety and depression, fluoxetine, escitalopram also can be used, but fluoxetine, higher dose for anxiety, lower dose for this thing. Mania, we should only use carbamazepine or now oxcarbamazepine because of the Stephen Johnson problem, but do not go for lithium. We should never use. Pediatricians should not use lithium because lithium, the therapeutic dose and the toxic dose margin is so low, it should only be. And psychosis, risperidone, we are using left and right now, autism, everywhere. Risperidone is a wonderful drug. It doesn't actually create all sort of problem. You can use risperidone, but make sure you use the correct dosage. That is very important. Now, this I don't know what is the time. I don't want to read it because but if what you can do is I'll put it. You can take a screenshot. How much time? Time is over. 5 minutes. Okay. Then no problem. Now this is important. This is actually published information. Myself and Paul Russell. Do you have difficulty in focusing on any task? Reading, for example, it is attention deficit. Do you have problems sitting still? Attention deficit. Do you have involved in setting fires, stealing? Naturally, conduct disorder. Have you been suspended from school? Conduct disorder. Have there been any change in your sleep, appetite, or bowel habits? It has to be anxiety or sometimes depression. Okay. Do you wet your bed? Again, in an adolescent, I am saying, not small one. In an adolescent, It could be anxiety or it should be anxiety or depression. Do you feel nervous again in front of others? Social anxiety disorder. We all had, not that we all had sometime or other. Do you have fears that are perceived by others as unreasonable? I have written here social anxiety, but it may not be. It could be early evidence of psychosis. So it's important to take it. Just think, how in the back of the mind, it may not be social anxiety alone. It could be delusion also. Do you worry that terrible things might happen? Again, separation anxiety in a child, but beyond that, it could also be part of the psychosis group. Do you repeat acts over and again? Naturally, obsessive compulsive disorder. Do you feel sad and not happy as your friends? Depression. Have you ever thought of hurting yourself? Depression. Have you ever been troubled by thoughts that you are unable to control? Your thoughts you are not able to control. Again, depression in a simple one, but a complicated one could be psychotic depression. Just saying that. Do you think that you are hopeless or guilty in any way? Depression. Have you ever heard voices? This thing, hallucination. Visual hallucination, auditory hallucination. Do you think that anyone is against you, talking of you, trying to harm you? It has to be delusion, psychosis, early psychosis. If you are thinking that someone is harming you, talking about you all the time, somebody is trying to harm you, or everybody around is against you, problem is not theirs, problem is yours, you are having delusion. Of course, tobacco, smoke, alcohol, substance abuse. The last word I would say is take care of your health. Do not get into trouble. Times have changed, particularly male pediatrician dealing with girls. Be very careful. Always have the mother with you. Sometimes you may have to, this is a very simple advice. Sometimes you may have to keep the mother out because privacy's sake. Then what you do is keep the windows open, pull the curtain away, have the door half closed only, not completely. Don't lock the door, just leave it like that. And before that, if you are doing at home, at hospital, a nurse should be there coming and talking to the child, or assistant should be there talking to the child. If you are at home, either your wife or your child or grandchild should come and talk to the patient. Because that actually what I used to do is my wife used to come and ask. I have said it many times, she'll come and I better, pani chahiye, chai and all. She has never given tea. But I that ask him, make it, it's last 40 years, she has not given at all. But it helps a lot. Now, actually, it's taken care of my grandchild, because she come and play with the girl, and naturally she become very friendly. Suddenly you become the grandpa. So the girl feel more comfortable. So use any technique. And I think Tutaja Saab doesn't need all this. His face shows great grandfather, but we all look too young. What is the problem? Atul also may need simple technique like this. For ladies, absolutely. Be careful. Very few, rarely the boys can complain against you. In England, it's very common. So in the MRCP, they teach you all this. But India is not there, except one case I have heard. So you don't have to be too much worried. Ladies don't have to be worried. So if adolescent has to grow, the ladies, pediatricians have to come forward. The others can be behind pushing the thing. Thank you. Thank you very much.
Thank you so much, sir, for such a wonderful session. Counseling is really very important topic and difficult as well. But you have enlightened us in a very structured manner, which will be definitely useful for us in day-to-day practice. Any questions can be put in chat box, which we will take in the end after the next session. So for the next session, I call upon Dr. Vaishali Deshmukh, madam. Her talk is on counseling of adolescents and parents about sexuality issues. Dr. Vaishali madam is in charge of 9 to 19 clinic in Pune, Dinanath Mangeshkar Hospital, and at Bharati Vidyapit Hospital, Pune. She has conducted many workshops for parents and adolescents. She has many researches in index journals. And what is more remarkable in her journey is her book on teenage.com, which has received award from Maharashtra State Government's Literary Award and also Yadunath Thatte Wangmay Puraskar. Recently, her second book, Teenage.com 2, has also received Maharashtra State 2020 Literary Award. Both the books are available on rajhans.prakashan.com. I invite Madam on the virtual dais for the next session. Dr. Vaishali Deshmukh, Madam.
This is my counseling assistant.
So sweet she is, sir.
Yeah?
Really an inspiration.
Yeah.
Yeah. So can I share the screen?
Yeah.
I have to stop share now.
Yes,
yes,
sir.
sir.
Yes, sir.
So thank you so much, IIP Nasik and all the officials, and of course, I'm so grateful that I have been invited to talk today, and because of the presence of Dr. M.K.C. Nair as well as Dr. Tuteja, it's a great opportunity.
Madam, one apology before you start. I had given a time for recording at 12 o'clock. So if they come, I may have to disappear. Sorry for that. Okay.
Okay, sir.
It's actually adolescent only. 2 topics to be recorded. The only time they had was 12 o'clock because the camera has to be available.
Vaishali, one sec. Trupti madam, before sir leaves, if anybody has any queries on counseling, can Vaishali madam pause for a minute?
Yes, sir. I'll just check. I think, Atul sir, questions only. What about loss of interest in sex or other enjoyable activities and as an indicator for depression?
It's an extremely important one. For male, it's so easy to find out because you just ask him how many times. He will say, I'm talking about masturbation. He will say, oh, I used to do 3 times a day. Now how many? Last 3 months not done. Very easy. Girls, it may be little difficult. One, to ask her like that may not be easy. Secondly, she herself may not be doing it, or she may not be aware of it. But if it is a married couple, 100%, you can find out. It is one of the best indicator for depression. Now, sexual issues are the most critical issue in marital relations. But in children, of course, you have your embarrassment in asking, even if appropriate, not appropriate. Anything else, Atul? I think you will be able to answer even more.
Yeah, no, it's okay. I had one more question that was in the first slot. What are the indicators? You said some environmental factors for let's say responsible for
scholastic.
Behavioral issues.
Behavior issues or scholastic issues?
Scholastic worsening.
Scholastic worsening can be divided into 3 environmental. One, acute something. For example, I'll tell you, just yesterday somebody consulted me. It so happened that teacher was so fond of the girl. Actually, he hugged her something. Okay, which 99% I believe it was out of affection for the child. When the child is so brilliant, so nice, you may do, but inappropriate to do actually. But 1%, of course, may be other intention, but that has destroyed her studies completely. Now, you may laugh at it. Is it such a big thing? But for that particular child, it's enough. So these are the acute things like that. Chronic is the feeling that I am not being looked after by anybody. I'll give you the example. If you are teaching nursing students, there will be 48 for 50 girls and 5 or 6 boys. They always have problems that these teachers will look only at the girls. They only play fool with the girls. They will only do that. So what I do is always I make sure that out of the way I talk to the boys and praise them, and I say one thing, these girls all may be looking into eyes and saying all this, but 5 years down the line, if they see you on the street, they will look at it. Whereas these boys who are looking, doing like this now, they will come running, sir, you are my student. They feel so great about it. You understand my point? So this is a sort of way. The person, everybody has to be taken care of. That is important. And you must have the thing to know. Somebody is not really good looking. Somebody is very dark. Not that dark is bad, but perception is like that. Somebody doesn't have that. He has. Actually, I had a girl who has some problem on the face, this thing. I go out of the way to make her feel good about it. That need to be done. Otherwise, sometimes they get negative ideas in the school. And very often, third most important thing is unintentionally we make comments that can destroy the child. Okay, that one simple example, I said a small child came to my room. I call him Mota, just like that, Mota, oh, Mota. Next time child won't get into my room. So I told the mother, what happened? She said, no, last time you called him Mota, he's not refusing to come. I had to go out, apologize, do this thing, pick him up and say that you are like Ganapati. That worked. He was a Hindu. So I said, yeah, I said Mota because affection for you, because I brought him inside and showed Ganapati's photo and said, see, I pray Ganapati, so I so affected love. That's why I did it. Child, because he's a child, he thought I am right. And he accepted. So such things have to be done.
Yeah, sir, we also have one more session with you, maybe in the next few months or so, on parenting. So that time, family dynamics or family problems as a environmental factor that can be discussed that time. Is that
And
okay,
most
sir?
important, I forgot, most important, see whether there is drug in the school or near the school. That is the worst thing that is happening now. And the toilets, lot of sexual activity happening in the toilet. So
especially in the boarding schools, it's very much common.
Yeah, lot of activity happening, lot of activity. Now, then, of course, somebody asked me the question, if girls themselves, they do something, boys do something, should we bring into book and all? I said, forget it. Forget about those things. So long as it is not an elder child doing on a younger one, forceful. If two people like and they want to scratch each other, let them scratch. That is not, you don't have to lift all the, towels and see, or the bed sheet and see. That much you don't have to. But if it's an elder child, boy or girl, disturbing a younger one, then it's not tolerable. Okay.
Yes, sir. Thank you so much.
Without saying, I will leave. As soon as they.
Thank you so much, sir. Thank you so much. Thank you. So over to you, Vaishali madam.
I'll sit for your talk as much as possible. Vaishali, I'll sit as much as possible.
Yes, sir. That will be great. Thank you. Yes, so with his usual skill, Dr. M.K.C. Nair has. Am I audible? Dr. Praveen Pawar needs to mute.
Kindly unmute all your laptops or mobiles. Kindly unmute. Let only Vaishali madam be on. Okay.
Yes, ma'am. Yes, sir. Muted all. Thank you.
Yes, so we heard a lot about counseling of adolescents and parents in the last 40-45 minutes, and it was wonderful. Now attach this part on sexuality, and then generally most people are taken aback. Okay, counseling is fine, but sexuality counseling, why is it needed? Why should we do it? And things like that. So let's see what it is about sexuality counseling that challenges us. So 36 seconds isn't enough. You might wonder, what is this statement that I'm making? So Alexander et al. Had done a study in 2014 on 253 adolescents and 49 physicians during their regular usual health maintenance visits. And an audio recording was done and that was analyzed. And it was found that only 36 seconds on an average were given on sexuality during that session. And 35% of the times, that is 1/3 of the times, no mention of sexuality was made in the routine health visits of adolescents. Now, we all know that sex and sexuality are uppermost in the minds of adolescents because that is where they are developing and evolving at this age. But that is what it is. And I think our adolescents, they need better. I mean, 36 seconds isn't really enough. So then let's just look at why do we need sexuality counseling in the first place. So we know that knowledge is power, and what we are trying to do through counseling is empower the adolescents. Most of us are parents of adolescents, or at least we're dealing with adolescents, and we know that adolescents, if we give advice to an adolescent, he's not going to listen to that. but empower him to take a decision, and that might work. So knowledge is power, and we have to empower the adolescents with knowledge, and that's what we do in sexuality counseling. Of course, we all know that in spite of the fact that there are temples and lots of information on Google, this subject is shrouded in mystery. So people don't really talk about it. People don't mention the word. They never mention the anatomical names of the organs. And on the other hand, there is rampant availability of age inappropriate and unscientific information on the net at the click of a button. And exposure to sexually loaded content. The other day I was watching a web series, and I almost I switched it off in between because there was so much sexual depiction in that, and nothing was left to imagination. And imagine all our kids are watching these web series without any censorship. And there is widespread ignorance regarding sexuality. Supposing even if you ask an MBBS graduate, what is the difference between sex and gender and sexuality and sexual orientation and sexual identity, I'm sure they will say what all of them are the same. So there is a widespread ignorance. There are lots of, and this breeds a lot of mental health issues. So I'm sure some of you have watched the newly released OMG movie, and it addresses the issues of mental health arising of ignorance about sexuality issues. So it may be about masturbation, it may be about size of the breasts or penis or whatever it is. And we know adolescents are curious, they are experimentative, and they have a very much concrete mind rather than an abstract mind. So they think here and now, and they want to explore things on their own. They don't want the opinions of the others. And that's the reason why they are so curious and experimentative, and that can lead them into problems. So obviously we need to address this issue in our clinics. I'm sure you have seen this Erickson's developmental tasks model. So Erickson says that at every stage of development, we have to acquire certain tasks. And the task for adolescents is identity versus role confusion. Now, adolescents are trying to establish their identity. They are trying to find out, who am I? What is my place in the society or in the family? What is my political identity? What is my religious identity? And most of all, what is my sexual identity? And that is the reason why it takes such a lot of precedence in the adolescent's mind. The parents sometimes come to us and say, my child is always, watching pornography, or all of them are always teasing each other, sexually, or having a lot of sexual talk and getting into relationships and out of it. Actually, at this age, studies are important. They should think about their careers. But when we look at it from the adolescent's perspective, studies, career, it is part of their life, but it is a very small part of their life. All these other things like friendships or relationships, their body image, their emotions about all these things, the virtual world, all that is, having a huge bite of their life. And that's why the perspective of adolescents and parents is different, and we have to really be aware of that. And then why physicians? Why are we saying that we should, counsel them about sexuality? So first thing is initiation of the subject. Now, the study which I mentioned initially by Alexander et al., they found in that unless the physician initiated the topic of sexuality, it was not discussed during the session. So very, very few adolescents themselves will bring up the subject of sexuality or sexual issues. They will come to us with some other problem, and then we have to really explore further and find out. So the physicians are in position to initiate the subject. They have access to scientific and evidence-based sexuality information. As we already talked about, there is so much of inappropriate information, unscientific information around us, which is so accessible to adolescents that somebody has to give them proper information, which is scientific, which is evidence-based. Also, physicians have a sort of comfort level because they have learned all this in the college. They can look at it, objectively, because reproductive system is just another system, just like respiratory system and nervous system for us. And also, the most important is they have an opportunity. Adolescents do come to them for some reason or the other, maybe vaccination, maybe certificates, or maybe some illnesses. And we can go do this heads assessment through which we can approach the subject of sexuality and make sure that the adolescents understand that. Not only that, we are looking at children right from their birth, and we know that sexuality education starts right at birth. So we have an opportunity to initiate the conversation. We have an opportunity to develop the conversation over a period of time during the subsequent visits, and also to make the parents aware about the importance of sexuality education. So are you all convinced that physicians have to give the sexuality education to them? Now, this is a little complicated model, but you can look at it from find out about it later on. But it shows that there are multiple aspects and to the physician adolescent discussion about sexual health. So it is not just a 2D or 2D information. It is a 3D, three-dimensional model where clinical education matters, where sexual topics are important, and the infrastructural support also matter, which include the parents, clinic staff, healthcare system, and the whole society as such. So then what do we want to achieve through this sexuality counseling? We want to help the adolescents build confidence in their quest of sexual identity, because everybody else is telling not to go in that direction, and their mind is telling them to go through that direction. Their body is telling them to go in that direction. And so they are getting really, really confused. And so we are the ones who can actually build confidence and stop them from getting into, say, body image issues or loss of self-confidence or doubts about themselves and their sexuality. It can result in reduction of sexually transmitted infections and unwanted pregnancies. We can also help negate misconceptions, because so many things are shrouded in mystery. There are lots of misconceptions about masturbation, about pregnancy, about how a baby grows inside a mother's tummy, and a lot of other things. And also about relationships, saying no, and getting into relationships and out of it. So we can negate the misconceptions by this counseling. We can prevent and manage psychosocial issues. And of course, I think the biggest outcome of this counseling can be to promote healthy and positive attitude towards sexuality. Sexuality is not something bad. Sexuality is not something that has to be avoided. In fact, it is a very, very important part of our life. And it gives us a lot of boost and energy. So if we teach adolescents how to approach sexuality in a healthy way, with a positive attitude, it will be actually beneficial to the whole society and its fabric. Also, to create awareness amongst adolescent stakeholders, because just the physicians cannot do everything. We have to include the teachers, the parents, the peers, and the rest of the society. To prevent sexual abuse, because we said knowledge is power, and that power can help adolescents and children to avoid sexual abuse, and to empower adolescents to take informed decisions, because they are at crossroads in their life, and they have to take a lot of decisions now regarding not just their career, but also about their partners, their sexual preferences, their body language, their attitude and behavior as a man or as a woman in a society, and a lot of other things. And so we have to start right in the childhood. So to normalize all these changes, to normalize sex and sexuality, we have to assess the risk. For example, we have to find out if there is this is a broken family, if there is some issue in the family, if the child is already mentally disturbed, or if it is being bullied in school because of some sexual issues. It has to be age and need appropriate information. Like, for example, if a child is going to go to college now, we have to teach them how to, learn to say no. We have to teach them safe sex, and we have to teach them the importance of consent. Then we can do preventive, curative, and rehabilitative counseling. I think as physicians, we are all aware of these terms. And we know that when it comes to sexual issues, we can give them anticipatory guidance, which is the preventive counseling. We can counsel them out of the misconceptions and myths or mental health issues which arise out of sexual misinformation, and then rehabilitate them. For example, if a child or a girl has gone through, say, sexual abuse or unwanted sex where she could not say no, We can teach her how later she can empower herself to say no. We can teach her how she can, not blame herself for the whole situation and come out of it, successful way. So this is an age-old debate: what is sex, what is sexuality? And this small little wheel, I think, really gives us a good idea that sexuality includes not just the body, but also the thoughts and the feelings, the gender, the relationships, and the values and beliefs regarding sex and sexuality. So this is a long list. What exactly includes, what do we include in sexuality counseling? So it is reproductive anatomy, physiology, sexually transmitted infections, myths and misconceptions, pregnancy, contraception and abortion, sexual abuse, relationships, sexual orientation, sexual identity, gender, pornography, life skills, the emotions related to sex, laws such as POXO, and sex and cyberspace, where internet occupies a huge role in today's sex and sexuality. So it's a long list and it is still not completely complete. So you can complete it further, but these are the majority of issues, main issues which we encounter or address during our counseling. And so the counseling has to be tailor-made according to the needs and maturity, and there has to be confidentiality with exceptions. What do we mean by that? Now, unless we give them assurance of confidentiality, the adolescents do not open up. So we have to really give them that assurance. But since they are minors by law, there are certain limitations to that. So we can tell them that this will be confidential between you and us. But if there is some point which is against the law or which is harmful to you or somebody else, or something that I feel is not really good and it can be dangerous, we will discuss it together and make sure that it goes towards your parents. And they really appreciate that, because many times they do want to share it with their parents, but they don't know how, or they're scared of their retaliation. And so if we promise to handhold them in this process, they're really happy and they want to share it with their parents. And our attitude as a counselor or as a pediatrician, we have to be comfortable, because adolescents have that sixth sense and they immediately pick up if you are uncomfortable. And then they, stop believing in you, and or they start asking you questions to make you further uncomfortable. We have to be non-judgmental. What do we mean by that? I have my own opinions, right? So I can't really be neutral, or I can't really accept everybody else's opinions all the times. So I have to keep my own, say, moral values or opinions to myself. Being non-judgmental is not judging the other person for thinking in that particular manner. So we can accept that this person can think in this manner. Many times they feel that why sex is so, made such a problem. We can all have sex. It is my right. So even though I don't feel it that way, I have to accept that he may feel that way. Then how do I address that? I just discuss it with him. I'll tell him that, okay, then we'll discuss a little bit about it. I'll tell you some, consequences of this and the reasons and the laws and everything. And then you take a call. So we make them aware of the issues in it and then help them take the decision. We have to be confident and knowledgeable and proactive. And if we are not knowledgeable about something, because adolescents do ask us some questions about which sometimes we're not really aware, especially when they're related to cyberspace, then we can always say that I really don't know about this. I will look it up and then we'll discuss it during our next session. And then they appreciate that honesty also. Now, when we counsel the parents to counsel the adolescents, they usually face this situation. There's no need for the big talk. I have seen it all on TV. They've already seen it, they have watched it, and they know too much about it. Then what do the parents do? What do they talk to them about? So they can have something called as a window approach. It cannot be one particular single large session about bees and birds. It has to be something like this. This is a beautiful picture of the river Nile, and this is supposed to be the longest river in the world. So like this river, this conversation has to start with a trickle. It has to take, it has to expand and become more and more active as time progresses. And ultimately, it has to reach the sea of knowledge. So this is a lifelong conversation. This starts small, but starts getting, speed after some time. And that is how parents have to approach it. So window approach is something Dr. Sheshadri has suggested. So he says you can take those opportunities or moments, talk about that. Say, for example, you can talk about consent at one point and not really go into how the ovulation occurs or, how a baby is formed. So one thing at a time, but seize the moments and talk about it. So that is what we have to tell the parents, because even though apparently adolescents know everything, it may not be age appropriate and it may not be scientific. So these are the few, cases for which they come to us, just a few examples. So the names are imaginary, of course. 16-year-old Sumedh thinks he's gay. 14-year-old Neha hasn't got her periods yet. A boy and a girl are sending each other sexually explicit texts and photos. A mother is worried that her son spends too much time in the toilet. Does he masturbate there? Amit is really angry that only girls were allowed to sit in the bus and the boys were asked to walk. An adolescent recounts being sexually abused as a child. Atharva is teased in school because he talks like a girl. Now, you know what these things represent. The first is about their sexual orientation. The second is about their physiology of sex. The third is about cyberspace and sex. The fourth is about myths and misconceptions about masturbation. The next one is about gender. The next one to that is about sexual abuse. And the last one is about sexual identity or gender identity. So these are the various things for which they may approach to us, but sometimes they may approach to us for, say, academic failure. Sometimes they may approach to us for depression, sometimes for aggressive behavior, sometimes for crimes. And ultimately, like the tip of the iceberg, we will find the whole iceberg below, and then some of these issues might come up. So, sir, do we have time to discuss 2 or 3 situations?
Yes, ma'am. You can go ahead. Yes.
So Benu wants to know why adolescents are not allowed to have sex. Now, how do we approach this case? So ideally, I would have liked to ask you this question, but since we do not have too much time, I'll go ahead. We can discuss about what does consent really mean, because whenever anyone has sex with someone else, there are 2 people involved in it. So consent is very, very important, and we can discuss about that. We can also touch upon the consequences of sex, such as unwanted pregnancy, sexually transmitted infections, emotional issues, and some other things. We can also talk about the law about sex. And then we can say that, see, these are the things. Or we can tell them an anecdote, such as, see, there was this boy who came to me and he was blamed by another girl for under the POCSO Act that he touched her inappropriately. And the police took him to the juvenile detention center, and later on it was, the case was withdrawn and he was found to be not guilty. But the whole experience was very, very traumatic for him. He was in the 10th grade at that moment. He missed his exams and he wanted to become a doctor later on, but he just could barely finish his BSc. So these are the consequences. We have to really sometimes explain to them, because they can't think too much into the future. And so they look at immediate gratification. They look at immediate, advantages, and which is why they have these sort of questions. So instead of laughing at them or instead of trivializing these issues, we can actually discuss it very, very seriously, like an adult to adult with them, and touch upon all these aspects of this decision. They feel that this is just a right of me. So right is right, but there are consequences and laws. So think about all that and then take a decision. So the next one is, and also we can talk about accepting no, not, and also saying. So these are good opportunities for us to talk about this. Another boy who came to me said, I think I'm gay. So what is the inappropriate response by a physician? A physician might say that, oh, don't talk about that right now. Oh, this is not the age in which you will understand all these things. Wait for some time. So, or sometimes he may say, oh, no, I think you're reading too much nowadays about all this LGBTQ. Stop reading all that and this will go out of your mind. So all these are inappropriate responses. It might be a misconception of that boy that he is a gay, but this is not how we should respond. So what is the appropriate response? We can just say, oh, is that what you think about? what I wonder, what made you think like this? So he may, tell us some incident which happened because of which he started thinking, or something that the emotions which come to him when he's with his friends. So then we can just listen to them and reassure them. And then we can say that, yeah, usually the attraction is of opposite sex, but it can be of the same sex sometimes. And you can have a lot of questions in your mind about LGBTQ, and it's not a very simple subject. And let's do one thing, let's give it some time, think about it, and we'll meet again and discuss it again. So already this boy is probably feeling much better after discussing about it in a very, adult to adult manner. So next time when he comes, he will probably be much clearer in his thought process. And he will be reassured that he may or may not be gay, and whatever it is not really a crime or a problem for him. A mother is worried that her son spends too much time in toilet. Does he masturbate there? So this is how they will usually address the situation. Both of the parents will gang up against the child and they will, give him a big talk or something like that. But what do they have to do? They have to we have to address the myths. We have to educate the parents about the myths about masturbation. And then their attitude towards the child will definitely change when they will realize that this is a physiological thing and not pathological. And this is, I think, the last one. Chetan is addicted to watching pornography. So again, we don't have to be, even if say, I don't like watching pornography, I don't have to say that what is this dirty thing you are doing? And I don't know why you children, watch this pornography. That is not the thing that we have to do. But what we have to talk about is why pornography is considered to be non-watchable. We can talk about how it is, spiced up, how it is sensationalized, how there are a lot of photoshopping done, how these participants take a lot of hormones and undergo a lot of surgery so that they look perfect. And all that distorts our way thinking about sex and sexuality and their body. And we can then talk to him about what is it that he can do. So apart from, surfing in a common public area where he will not feel, be tempted to watch pornography, he can also engage himself into these physical activities, his hobbies and things like that. And automatically his attention from porn will go away from it. So I think, and when there is sexting and sexuality, we can again take that opportunity to talk about online sex and online love, which is a major part of adolescents' lives nowadays. So these are just few examples, and I know that this is not the entire process of counseling regarding sexuality, but I think that is how we approach it. So thank you so much.
Thank you. Thank you so much, ma'am, for such a wonderful session. The topic is really very sensitive, but you have covered it in very thoughtful and interesting way. So thanks for the session once again. Any questions can be put on the chat box. And there is a request from Kanika sir for Tuteja sir to comment about the vital reason for imparting sexuality education. Dr. Tuteja sir.
Tuteja sir, I think has left.
Has left?
Because he is in US and by now it will be midnight there. So
okay,
for his age, it's better. But it was a wonderful talk, Vaishali madam, as usual. And very well studied and very well formulated sort of presentation. But what sir has told me always, Tuteja sir, I actually wanted him to comment on this. That he said why we should impart sexuality education is that is the best way to prevent sexual abuse in children and teens. So unless, as you mentioned in your slide, Vaishali, that what we should teach and what we should talk on sexuality. But this one thing is the major preventable cause for sexual abuse in children. Unless we teach them what is appropriate, what is inappropriate at the right age, as you said, right from birth, the education should start. But earlier we do, and now we should focus more on preteens. Because abuse is a very big topic, but most of the girls especially suffer from this particular abuse when they are around 10 to 13 years of age. That is the most common incidents where the girls face these types of inappropriate advances. That is what I wanted, sir, to talk about. But it was really a very enlightening and very well studied presentation, I must say. Very well studied.
Thank you.
Thank you, sir. So there are no more questions in the chat box. So should we conclude the session?
Please, madam.
Yeah. So thanks everyone. On behalf of Maha IIP and Nasik AHA, I would like to thank both the stalwarts of today's session, Dr. MKC Nair sir and Dr. Vaishali Deshmukh madam. I would also like to thank Dr. Rajendra Kulkarni sir for being MMC observer for the session. Sincere thanks to Dr. Ramakant Patil sir, President Maha IIP, and Dr. Amol Pawar sir, Secretary Maha IIP, for their wholehearted support for the program as usual. Thanks to Dr. Atul Kanikar sir for being coordinator of the path and arranging such brainstorming sessions on every Sunday, first Sunday of each month. Thank you so much, sir. Thanks, Pallavi madam, for your technical support. And lastly, thanks all the audience for your patient listening. We are waiting for you for the next session in October. Thank you, everyone. And with this, I would like to conclude the session.
Thank you.